Hey there, friends. Welcome to this week's episode of the Pain Science Education Podcast. Today, we're discussing the crucial role physiotherapists play in supporting mental health. In today's episode, we'll uncover the ways that physical therapists can identify and address signs of psychological distress in their patients. We'll talk about yellow flags as well as red flags and how you can implement effective assessment and management strategies for things like pain catastrophizing, depression, and how to screen for suicide. Joining us today is Ryan McGrath. Ryan is an Australian physiotherapist and early career researcher. He is exploring the intersection between physical and mental health, and his PhD specifically looks at ways physiotherapists support clients with psychological distress. So whether you are a physical therapist, a physiotherapist, or another health professional, and if you're curious about the intersection of physical and mental health, this episode is for you. Today, we'll dive deep into the ways to assess and manage physiotherapy clients who are experiencing psychological distress. Okay, without further ado, let's begin and let's meet Ryan McGrath. Hi, Ryan. Thanks for joining me on the podcast this week.
Great to be here, Joe.
I'm excited to speak with you. I know you're leading some really amazing work in the realm of physiotherapy, psychologically informed physical therapy, mental health, suicide. We're going to talk about all those topics today. You have some great research papers that I mentioned during the introduction to our episode here today. So people will be sure to link to those and click on those and read them. I guess just, a good place to start is how did you get involved in kind of the mental health physiotherapy world, which is a small yet rapidly growing part of our practice?
My introduction to mental health physiotherapy probably came from when I was a physiotherapy student. I remember being on a placement in a neurological ward doing a bit of rehabilitation. And I encountered a gentleman. He was in his 50s and he'd just experienced quite a dense stroke. And as you can imagine, the grief and loss that goes through it, he was in his 50s. So one day, the previous day he was at work, and the weeks after that, his life has changed. I remember meeting his wife. She was there every day when we were doing rehab. And she was talking about how they had planned a holiday, and they were talking about all their retirement, and she was going through quite a significant grieving process. And for me, I'd always had a bit of an interest in mental health and psychology anyway. Considered that as an alternate career. But it really showed to me that, we can't separate the physical and the mental health. It was a bit challenging because whilst we did have social workers, we know from the literature and we know in this situation that there's not a lot of support that's often given to people with post-stroke in terms of their mental health. So that really showed me the relevance of physiotherapy and psychology and mental health to me at that stage. I studied a little bit in psychology during my physiotherapy degree, studied a graduate diploma, which was actually a bachelor's at the time because I hadn't finished my physiotherapy degree at that stage. And when I went through that process, I came into the area of persistent pain. And obviously there's a huge movement within psychologically informed physiotherapy, at least in the literature. We'll see to the extent that's influencing practice. But it seemed a very natural conclusion that, we're talking about these psychological factors, we're talking about pain-related distress, and at times we're talking about depression and anxiety, but we're not really provided a lot of guidance around how to handle those situations. I had experience volunteering at Lifeline, which is a crisis call centre here in Australia for suicide. And for me, that program was about training people up within 6 months to be able to respond to phone calls and be able to handle those situations. And then, in 2 years, you've pretty much completed your training. So that's, taking people with no health professional qualifications to that level. And when I was reading this literature, particularly there's a paper around cognitive functional therapy by obviously Peter Sullivan, and I have huge respect for the work that he's doing. And it was talking about the type of things that you might hear from patients. And again, they were all saying about, does the pain get you down? Do you feel like there's any way, forward? And the sample responses was, I feel hopeless. I see no way out. And for me, with my background in, that Lifeline training, I'm going, that's an invitation to ask about suicide. But obviously, papers are pretty not, tightly focused, and being able to cover that type of thing. And that wasn't the purpose of the article, but that really showed to me as a student how important, essentially mental health was to all areas of physiotherapy, but particularly pain-related stress, like persistent pain. So then that kind of got me interested in what do we do in mental health? There's not a huge group of Australian physios involved in mental health physiotherapy. So I joined the national group, wrote a paper for my honours around the experiences of physiotherapists with clients with suicidal thoughts and behaviours. and really found a good community within that mental health physiotherapy space. So there's obviously mental health physiotherapists in Australia that work in mental health services, but the group that I've really resonated with are, physios working in all settings. I work in community health, had experience working in a refugee health clinic for a little bit. And for me, that's where I see mental health physiotherapy. That's where I see psychologically informed physiotherapy.
Mm. Really interesting. It's a great way to start. And I think one of the points that you brought up, I think is so key that as licensed health providers, we're afforded these opportunities to open doors to these conversations. And I think, we're going to get into the detail about that today. But I think the most important part is obviously identifying and screening for this kind of as a first step, which some of our colleagues are doing quite well. And others are, still just kind of learning what this is about and how to go about doing it. In some of your, I was reading through some of your papers, and there are a lot of terms in there, and I think we should break down some of these terms just so physiotherapists and others understand these terms. So you talk about in your one of your articles, health-related distress, pain-related distress, and then psychopathology. And I'll say those again. So health-related distress, pain-related distress, and psychopathology. And maybe you can just kind of explain to us. I know there's some nuance in there and there's some overlaps, but what are the differences between those three? And I guess where are we working as physiotherapists with regard to those three topics?
So that's a very interesting question. So when I was looking at doing my paper around the experiences of physiotherapists with clients experiencing suicidal thoughts and behaviors, I'd originally thought about looking at mental health more broadly. But I had a group of very experienced supervisors. We're going, don't tackle topics so large. We have to kind of narrow it down. So that's why I looked at suicide. And you won't see, like, suicide might be a symptom of depression. It's associated with a whole range of mental health conditions, but it's not a diagnosis. So when I moved into the PhD, I had a fortunate period of about 6 months, and I was studying psychology through that process and was able to really engage in the full breadth of what are we talking about when we're talking about mental health conditions? What are we talking about in mental health? What are we talking about, like, in flourishing and languishing? And what is this concept of psychological stress? Because we don't see it that much, but for example, the term pain-related distress, physios talk about it, particularly in the psychologically informed literature all the time. We're talking about pain catastrophization. We're talking about, again, that's pain-related worry, because I'm not a love, obviously, the term catastrophization. We're talking about fear avoidance. We're talking about, this health-related distress. This may or may not be associated with an underlying, mental health condition that could be diagnosable. So psychological stress is typically characterized by depressions of symptoms of depression, anxiety, but it's much broader than that. It can include things like rumination, feelings of loss, grief, sorrow. It doesn't have to conform to any diagnostic criteria. So for me, when I was experienced in Lifeline, was we're not trained in that setting to go and make diagnoses. We don't care about diagnoses. We actually care about the distress that somebody's calling us with, and how to support them through that moment. And as a physio, that's what I see quite commonly. We've seen clients that, might be experiencing, the stress that's primarily related to their pain, or, the extension of that, meaning that they might not be able to engage in employment anymore. They might not be able to pick up their children anymore because they've got, experiencing low back pain or something like that. But we also encounter clients, and one of the studies that I published looking at physio's perceived frequency of contact with clients experiencing psychological distress was talking about things like financial related distress as well. And we obviously had the COVID pandemic, and a lot of isolation came out of that. So for me, that's what is interesting, is we see distress. It just happens one framework that has some value, and there is some criticisms of the medicalization of psychological and mental distress. But that's where our mental disorders come into. We have a whole series of criteria. And again, the purpose of those diagnoses are to inform treatment. But there is a whole, like, Lucy Johnston, Power Threat Meaning Framework, Corey Keyes. There's a few others that provide different conceptualizations of mental health. So that's kind of that background there. So much of the literature, obviously in physiotherapy, being led by researchers in persistent pain, has also been that kind of pain-related distress. But more broadly, we talk about, there's a few papers in neurological physiotherapy where they're seeing the same, similar things, grief and loss associated with changing circumstances in one's life, And that's, what I broadly categorize as health-related distress. But again, whenever we try to lump categories on something, things don't fit. And that's the challenge with writing about all of this type of topic.
Yeah, I mean, I really I appreciate you bringing up this, idea of distress versus diagnosis, right? Because for some professionals, when they first come to this space, they have an awareness that there obviously is distress happening, but they have a difficult time maybe separating distress from psychopathology. And there's, potentially some harm we can do if we kind of don't explain this correctly to people, don't inform them in a way, that is correct, because they might see this as not being distress, as you're describing, but being somewhat of a psychopathology.
Yeah, and what we'll probably see is distress is something that can range from absolutely very, very mild, normal responses that we would all expect with, injury or a significant loss or even minor losses, to anything that is quite severe and intense, may be associated with suicidal thoughts and behaviors. And those symptoms of distress or those behaviors associated with it may fit, criteria for major depressive disorder or generalized anxiety disorder and things like that. But from a physio's perspective, distress is distress. And whether or not it meets diagnostic criteria, I see that it's something that if I can help with, or if I can help refer to another clinician, it doesn't matter from my perspective whether it meets that criteria or not.
Yeah. I'm wondering if, as you've done your research, and obviously you've read a lot of research in the process, if you have a sense of kind of where we are as physios with regard to identifying unidimensional distress, because you obviously mentioned pain catastrophizing or just worry about pain as one, versus us starting to embrace a more multidimensional approach to distress, which is really what you're talking about. Because you're already mentioning topics, for example, grief is really not one that comes up that often in the pain related literature with regard to psychologically informed care. But I think we all realize that there is a sense, or there can be a sense of loss that happens with pain or with the loss of physical function that happens in someone's recovery. So just that, again, that nuance between unidimensional distress versus multidimensional distress.
And I think if we're talking about that multidimensional distress, particularly good article published on it was by obviously Peter Stilwell, and I think it was called Pain-Related Suffering. So suffering in that case, I'm probably going to oversimplify that very, very complex, philosophically driven article, but we're talking about really those severe forms of psychological distress that affects the intactness of a person themselves. So it disrupts their being down right at their core. And so when we're talking about multidimensional distress, there's a lot of tools that have been developed and a lot of great work behind them that have looked at obviously single constructs. And there's some amazing research. I think it's the Osprey YF has been able to collapse all of these unidimensional tools into a multidimensional tool as well. And the statistics of how that's happened is beyond my understanding. It is an amazing piece of work. But a lot of those ones are still geared towards essentially psychological factors, meaning that they're in relation to a, often physical health problem. And we're talking about pain, which I don't think should be classified as a physical health problem or a mental health problem. It is a health problem. And even that dichotomy between physical health and mental health is a problem in itself. But again, it's often, these are factors or in regarding to prognosis of something that traditionally physios see. Whereas when we're talking about these multidimensional aspects, we might be uncovering distress that is health related and non-health related. And there's a whole cascade that can happen. So, I think there's physios that I've spoken to as part of my qualitative research, they've had situations where they've had a client who's experienced chronic neck pain. And that has led them to essentially no longer be able to retain their work. Their family situation has then fallen apart. They're then isolated from their children. And then those, in this case, they were talking about those thoughts of suicide actually emerged. And then actually one of the physios that I spoke with, he was the last contact before a client who then died by suicide. It was kind of that progression. So it shows you how, one particularly life-changing event can lead into many others. And that's just one pathway that might happen. So that's where I see with those multidimensional screening approaches, they're a great start, but in some ways we need to broaden the scope of what we're thinking about when we're working with patients. For me, I'm a person first, health professional second, and physiotherapist third, and in that order. So if there are issues coming up with mental health, I may not be a mental health professional. That's not I'm not, It's not what I primarily deal with. That's not my strengths. But I still will sit with someone, understand their story, and see how I can help, including linking them into other services.
So obviously I'm in the US and we are rapidly waking up to psychologically informed care, I believe. I think we're, kind of well into it at this point. And I'm just wondering if, where you are in your country, if you have the sense that this is not optional care, like this should be required for new and obviously licensed physical therapists who are working in the field at this point. Because I think some people see this as, well, this is a specialty, and this is not something that I should be doing. But we all have thoughts and emotions and feelings that impact our recovery, and whether it's health, pain, or mental health.
And I can't recall who the author of this paper was off the top of my head, but there was an article published in Physiotherapy Theory and Practice around what are the qualities of a good physiotherapist. And all of these, qualities of a good physiotherapist is, from a patient perspective, is what overlaps with psychologically informed therapy and humanistic approaches to physiotherapy. So what we're talking about here in Australia is that we're seeing that same shift towards psychologically informed physiotherapy, but I don't think we really know still what it exactly looks like. And there was an excellent paper that was published, it was probably in the last year, by PhD student Miriam Dillon at the University of Queensland, and she looked at the concept of distress within low back pain consultations, so with physiotherapists and clients there. And we're talking about things like time constraints being an issue. So like we might theoretically know, and again, training at undergraduate level here in Australia includes some aspects of psychologically informed therapy, but probably not enough to actually have clinicians confident yet when they leave practice. But even those who are, if we're talking about running on 20-minute or 30-minute consultations, it's very, very challenging to be able to fit everything within that appointment. Lots of clinics are starting to extend their appointments, but then we run into, financial concerns. And for me, if we're talking about private physiotherapy here in Australia, we also run into the issue that the longer that we make appointments, and because Medicare rebates here in Australia aren't that high, we end up charging more, which leaves a group of people who are financially constrained, often highly distressed, left without services. And they're the ones that actually would really benefit from psychologically informed physiotherapy, but they often can't access it.
Yeah, so I'm going to give you a follow-up question to that, because I've thought about this too, and obviously the time is a challenge. But what's interesting to some extent, and I'll ask you this as a question, but I figured I'd just give you a little bit of time to think about it. In the United States, there are mental health providers, and I'm sure this happens in Australia too, where they're working in 30-minute treatment sessions. So they're using brief interventions.
Mm.
And there's some, good research around it. So that may fit into our practice, actually. So I'm going to ask you that question, if you don't mind. So I think that the time constraint is obviously a critical issue. There are definitely people who need more time. They deserve more time in their care and recovery. I also have colleagues who work in practice settings, kind of more behavioral health settings, where they have kind of shortened time. So they're psychologists or they're other mental health providers working in brief, like 20 to 30-minute sessions. And there's some research to demonstrate that we can get some good outcomes with that. So I wonder if, yes, we definitely have to advocate for more time with people with complex and comorbid conditions. But I think that we can deliver things potentially in a brief way and be helpful for people as well.
I 100% agree with that. The challenge, I think, in some settings, depending on how rigidly defined the referral is, if there's information all available, and then depending on how many side issues potentially emerge during a consultation. So a approach that I actually learned at Lifeline, they don't use this one exactly now, but I brought it across to physiotherapy, and I'll explain the relevance to my practice in a moment, is that use the model called CFRED, which was connect, focus the call, develop rapport, engage, coping, and decide next steps. And so I adapted it, obviously, to look at, rather than focus the call, focus the consultation. So sometimes when we start that consultation, I'll have a look at my referral, because I work in community health. So that's a MSK, predominantly persistent pain. There's not a lot of services here in a rural area of Shepparton, Victoria. So, again, it's a fairly high level of persistent pain. But when I'm doing that consultation, my first job is to try to connect with them. So that's that basis for that first consultation. And then I'll see where it goes, because I'll just have a pretty vague referral, often from a GP going, oh, this is going on, or this is going on. And GP, and many medical practitioner here in Australia, or family doctor. And that takes time. So that's a challenge. If everything's in order and you have a particular intervention in mind and it suits that individual quite well, then yeah, 30-minute can work. But I've got a colleague who works in the persistent pain space here in Australia in private practice, and one strategy that she uses is to essentially have that first initial consult predominantly dedicated to assessment. So you're not getting into interventions, and then you just break that across. You might even have a second consultation where you're still in that assessment phase, and you might be starting to integrate a little bit of education or a little bit of treatment here or there. So that's another strategy to overcome that. But it is just a challenging space, and I don't think we've still got that sorted here in Australia, at least, about how to handle these short consultation times.
Yeah, I mean that point of taking your time to assess, and then an assessment may take you the entire first session, maybe the second session, and kind of resisting that reflex that we have as physios to kind of jump in and show them the exercise or, target fear, let's say, with regard to pain. I think that can be so validating for patients because
Mm.
it shows that you care, that you're there, listening to them, giving them some space to talk and explain what they've been through, allowing them to ask questions, which can be very empowering for them before, printing out 2 exercises that you have to do for your back pain.
Yeah, exactly. And I think that's, if we're looking at persistent pain again, we're probably not the first health professional that they've seen. And they've probably done it for years and years and years. So how are we offering something different? How are we trying to make an impact that somebody else hasn't necessarily in the past? And I think there's that temptation that we feel pressure that we have to fix everything in that moment. And that translates very, very poorly if we look at mental health, is that another thing that I tend to find with the physios that I've interviewed, those who struggle a lot with engaging people, experiencing psychological stress, feel uncomfortable because they don't feel like they have the skills, and then they give them the expectation that they have to fix this at the end of this consultation, whatever's going on. And I think it's a bit of that, kind of hero complex that health professionals have, that we try to help our patients as much as we can, but some things take time and some things are beyond our control, unfortunately.
It's true. I've struggled with the hero complex myself, and it takes time, but once you get rid of it, it's actually refreshing for both
Mm.
you and the patient in a lot of ways. So we've talked a lot about distress so far in this kind of first half of this interview. I want to shift and I want to start to talk about suicide, which is another area of expertise of yours. Obviously, you've already mentioned some of your work in that area. Specifically with physiotherapists, though, let's kind of put that under the microscope for a minute. And where do you see our role in the world of suicide prevention, I guess you could say?
So for me, you've had a couple of previous podcasts. We had one recent, probably a couple of years ago or a year ago, with Tony Varela. He had a really good paper around depression. And I think the thing is, suicide prevention fits within that broader mental health physiotherapy or psychological informed physiotherapy space, or trauma informed physiotherapy. There's a lot of these terms going around at the moment, but it fits as an element of that. Because I'm not necessarily advocating that physios go out there and essentially add that suicide question to every single consultation just as a dotted line. What we're talking about is being attentive to signs of distress, and that in some cases that we may hear invitations that suggest that there might be underlying suicidal thoughts and behaviors. And if we hear those type of warning signs that there might be those thoughts, then it's actually our role as a health professional to get an understanding of, is this person at particular risk now? What is their ability to cope with these thoughts, and how well are they connected with other health professionals? So that's generally that role that I see that every physio, no matter what training they've got in the background, should be doing. It obviously gets a little bit more complicated because I think that there's a great number of physios, particularly those who are trained in psychologically informed physiotherapy and mental health, that can start to look at addressing the determinants of suicidal thoughts and behaviors. And that can be, exercise interventions, that can be general counseling, that can be psychosocial support, all of these things. But I'm not expecting every physio to be at that area of things. But all physios as health professionals should be able to, at least be able to have the conversation and go through that, initial assessment process with someone.
So when you say the conversation, I'm curious what that means to you, because there are some professionals out there, and this is not just in physiotherapy. This is in other health professions as well, that they're actually scared to have the conversation. They're scared to kind of open this can of worms, if you will, because they realize that some people are quite vulnerable and may be in a vulnerable place, But what does starting that conversation look like for you? What could that conversation look like for a beginner physiotherapist just starting out who's learning?
So generally speaking, it comes back to like I love that approach. That it's a bit cliche now, but that tell me a story that Peter uses. So really, we're talking about trying to connect and understand somebody's story. As part of that process, if we start to hear those signs of like mental defeat, perceived burdensomeness, isolation, that real profound sorrow, that's that clue to go rather than pull back and go, oh, that sounds uncomfortable, and let's go and have a look at your knee, or we'll do that assessment. It's just to sit with it and go and ask them to tell you more about their situation, and go that and empathize with them, sitting there going, that must be a really difficult situation. You don't have to solve it. You're just trying to understand what's going on. And that's important for your persistent pain assessment anyway. Like, it's all related. So it's not necessarily a particular suicide risk assessment or anything yet. As you keep going through that process, that's when we really, if we're hearing those type of things, we really want to ask that specific question, whether somebody is having thoughts of suicide. And then depending on that answer, then we need to look at whether somebody's got intent, they've got plans in place, and the imminency of those thoughts. So for me, it's just a very natural progression that you have with someone. It's not a additional assessment that you do. It's just a line of questioning that you end up going down if somebody's really, really struggling.
Yeah. And do you like actually including this in your verbal assessment versus placing key questions, let's say, in intake paperwork? And do you maybe have a kind of idea which is more valid, or do patients like one versus the other? Because I know some people, they're so busy, they're like, well, I just email the patient all the paperwork first and they fill it out so I can stick in this question in the intake paperwork. Versus sometimes there is a difference when you're sitting down with someone one-on-one and having a conversation, like you said, about, their story and what they've been struggling with.
So yeah, I have an interesting opinion around this, and I think this is an excellent area for further research and how we actually conduct that approach, particularly through using instruments and psychometric, psychological tools. Is that there was a paper that was, and I'm not going to remember the stats exactly, but it was a paper looking at screening for suicide within pediatric surgeon clinics, so in podiatrists over in the US. And I can't recall whether they had it just as part of their question. I think it was a part of a questionnaire that their nurse intake personnel would give to the client when they're coming in. And it was just like a tick box, are you having thoughts of suicide? And knowing the client base that they're working with, they had very, very few people that ticked and endorsed that statement. And that's my concern about those, essentially those questionnaires that have that tool. Is like, yes, picking up anybody through those tools is a good thing. And if it's more than what we're picking up already, then that's great. But we know from the literature and persistent pain, depending on how we define suicidal thoughts and behaviors, like if we're talking about death wishes, they're probably around 30% of our clients would endorse having those kind of thoughts at the moment. And then we're talking about suicidal thoughts and behaviors, which might be like in terms of suicidal ideation, probably around 10% that are having active thoughts. They're not necessarily going to act on that. So when we're talking about only 1 or 2% endorsing that through a form in that podiatry setting, that seems incongruent from what my understanding is. And there's a lot of stigma around reporting whether somebody has suicidal ideation. And also, if the particular client group that you're working with doesn't really have an understanding of what, they might have a cliche idea of what a physio or physical therapist is. That's just a physical health professional. They might go, why do you need to know that information? I don't want to just tick this. So for me, I tend to lean towards the interview-based process, because that's a bit more, that trauma-informed care, that sensitive way of going about this line of questioning.
I love that. Those are all really good recommendations and for things for people to think about. And I think kind of what you're really hinting at is it may be a good way to help the therapeutic alliance, which we're developing in the first or second, third, and obviously this is an ongoing relationship that we have with some people. And it's helpful to have conversations with people instead of, as you mentioned, just ticking a box. With so many people just move through fast. There are people with low health literacy who can't necessarily understand all the words that we're using as health professionals, and we should make attempts to, simplify things for them. But they're all really good recommendations, and we appreciate them. So let's talk about the thing that we usually don't like to talk about, which are barriers. What are the barriers to starting to address suicidal behaviors in physiotherapy practice specifically?
At this stage, I think it's all related, not all related. There's a large aspect of culture of what we see, what a physiotherapist is, and then by extension, what our education supports. Because it took me quite a long time, and this is, tangential to suicide, but, if I go through an initial assessment and I don't prescribe an exercise, I still feel like that's fine as a physio. But I felt, for a long time that I would have to do something movement related, and I have to cram it in. So even if I was running overtime, I'd, feel like I have to, they have to leave with something, movement based. And as soon as you release yourself from that, and then you also go, what do I actually have to cover in this initial assessment? I actually don't have to necessarily cover anything. We'll see where this conversation goes. That's something I think that's really empowering. Because when we go down that idea of somebody disclosing suicidal thoughts and behaviors, that might take up your full initial assessment. Particularly if you're in a 30-minute initial assessment, there's probably not that much else that you can do if you're going to do it sensitively and safely. And that's fine. And sometimes you need to even run over. So one thing that I found, again, this is where, for me, the CFRED model, the connect, focus the consultation, develop rapport, engage coping, and decide next steps was really helpful because, when we're going through that process, I try to connect with every single patient that I'm seeing. So I'm already going down that process. When we're talking about focusing the consultation, in some situations, I'm going back, the major distress is that, that pain-related distress, and I've got some tools that we might be able to work with someone and support them going down that area. But other times it is, we've got this disclosure of quite profound, mental defeat, burdensomeness. And for me, I need to just sit there and listen to that. And I rarely ever get pushback that clients feel like they should have got something else from that consultation because they felt heard and listened to and showed that we actually cared. And then we come back and we have a bit of a plan for our next session. So for me, it's about, if we can understand that we're actually, people first, health professional second, and physiotherapist third, then that frees our practice up to being able to be attentive towards, experiences of suicidal distress in our patients.
All right, Ryan, I'm going to give you two. So then you have two wishes as we end this episode. So the first wish is, what would you like to see change with regard to how physiotherapists address suicide?
So I think what I'd love to be able to see, again, within our education, that we're talking about psychologically informed physiotherapy needs to be mental health informed physiotherapy. It should be the same thing. And that we really need to be starting with a process that we take that. I don't want to overuse it because I don't think it's challenging to be holistic in whatever that means. But we need to be able to look beyond just the referral reason and go and say, what are these other issues that draw our attention? And once we start having that, then we can start having that training fall in line. So that's one thing that I'd really like to see changed. And there's a couple of states that have started to, I think Washington mandates training in the US for suicide risk assessment amongst physios. In Australia, we do things like mental health first aid, which is for the general population, but we really do need this high level training so that we actually are confident. So when you mentioned before, like the concern about opening up that can of worms, that we actually know how to respond and we don't feel like we have to just problem solve. And to anybody that's looking for a little bit more specific advice, I think you had a podcast a few years with Jane Rosenberg, and that type of pretty much everything through that podcast that I'd support in terms of physiotherapy practice.
Yeah, Joan is a wealth of information and an amazing psychologist who's done some research in that area. All right, wish number two. What do we change in physical therapist education or continue education, so to speak, to shift this toward a more, psychologically informed / mental health physiotherapy approach?
So while I'd love every single physio to be, highly competent and psychologically informed physiotherapy, because it's not limited to pain-related, persistent pain settings, or it's not related to, limited to neurological physiotherapy. It's related to all areas of physiotherapy practice. I really would like to see some basic competencies in terms of supporting people experiencing suicidal distress for all physios, but we really need to actually be paying attention to those particular areas of practice where the prevalence of suicidal ideation among client loads is quite high. So there's a paper that I'm hoping to publish soon that it had a very small number of Australian physios who endorsed working primarily in the area of persistent pain, but out of the 16 of them, 15 reported having had a client disclose a plan for suicide to them at least once in their career. So you go, if you work in that setting, we're talking about you actually probably need more advanced competencies, particularly if you're working in isolation and not part of a multidisciplinary team. So I'd love to see a more staggered approach to mental health and suicide prevention within physiotherapy.
you think we need a course in school? Like, right now, oftentimes these things are sometimes weaved throughout a curriculum. They're not necessarily part of a specific course. We've seen in the US, at least, some DPT programs have a 3-credit course on pain science education, let's say. Do you think we need a separate course on physiotherapy and mental health in the DPT curriculum or the physiotherapy curriculum?
100%, because I think that's essential, because we can go off and do the external courses, but it's actually being able to translate into that physiotherapy context. And all those barriers around culture, time, these are the conversations that you have to kind of work through as a profession, but also yourself, to be able to implement these, approaches within physiotherapy. So as much as we can bring that back to that discipline specific lens, I think the better.
Excellent, Ryan. It's been great having you here this week and talking to you on the podcast about distress in physiotherapy and how we can identify and address suicidal behaviors. There's super important topics, obviously, for the persistent pain physios, but really just for all physios, because we're all seeing this really throughout physiotherapy practice. So I appreciate you being here, and of course, the research that you're doing. Let everyone know how they can learn more about you and follow your work.
At the moment, I'm a researcher at the University of Melbourne. So if you just put in Ryan McGrath at University of Melbourne, you'll generally find most of my papers, because that's most of my contributions at the moment are through that platform. But I've got a couple of other podcasts and things like that I've been involved in, and a couple other sessions. So, just put me into Google and some things will probably come up.
Great. So, of course, all those links can be found on the show notes at the Integrative Pain Science Institute. I, again, thank Ryan for being here, and I ask you to share this episode with your friends and family on whatever social media channel that you're currently playing on. You can find me on all the channels at the handle at Dr. Joe Tata. We'll see you next week.